Bula Vinaka and welcome to Bula Wellness. I'm Dr. Alisha Sahukan, the Head of Health Protection with the Ministry of Health and Medical Services. In today's episode, we will talk about ischemic heart disease. Ischemic heart disease is the leading cause of death in Fiji and many other countries around the world. But we know of ischemic heart disease more because of its worst complication, heart attacks. Of course, it starts much earlier, and this is the point where we can do a lot more to prevent heart attacks. So in studio today, we will talk with Dr. Shaheen Nussair, who is a consultant cardiologist at CWM Hospital and is with the Ministry of Health and Medical Services. But first, we go to the streets to see what you, the public, know about ischemic heart disease.
What do you understand by the term ischemic heart disease?
Any kind of disease that affects the heart.
I believe that would be something to do with maybe a hole in the heart, or maybe it's due to genetics, or maybe blockage of the main artery, which actually causes heart rating problems or breathing problems.
Some of them have hole in the heart, and some of them like get it through smoking and drinking.
What are some of the symptoms of ischemic heart disease?
Well, I would say strongly is that there will be much difficulty in breathing, irregular sweating, like it will actually affect daily to daily functions of a person, and also, I would just say
Chest pains, tiredness, sweatiness.
Shortage of breath, sweating.
What are some of the ways you can prevent ischemic heart disease?
I would say actually you should know what you're eating and drinking. Lots of fluid is good, regular exercises, and also just knowing what you're eating, as well as just having a healthy lifestyle.
Improve your eating habits, eat more healthy, and exercise regularly.
Well, some are not curable, but some, like doctors, they're able to cure the patient that has heart disease.
Welcome back to Bula Wellness. In studio, we have Dr. Shaheen Nussair, who is a consultant cardiologist at the CWM Hospital. Welcome, Dr. Nussair. Thank you for coming on the show today.
Thank you very much for having me.
First of all, could you just tell me a little bit about yourself, your background, and the work that you do?
Yeah, so I graduated from Mosul University. It is in Iraq. That was many years ago. I obtained my master's degree in internal medicine from Fiji School of Medicine, and I got a fellowship training from Auckland. I have been working at CWM Hospital since 2002. We separated from internal medicine, and cardiology department became a standalone department by itself in 2009. I have been with the department since its start. I look after all heart disease that get admitted to CWM Hospital. I also look after the tertiary level care that are provided by the visiting teams when they come and provide services to our people.
Okay. So, like I mentioned in the introduction, ischemic heart disease is the leading cause of death in Fiji. Could you tell us a bit about what is IHD?
Yeah, so ischemic heart disease, I think it encompasses, it is a spectrum of multiple conditions. As you mentioned, it can be the dreadful end that we usually see at our tertiary level care hospital, which is a heart attack, but it usually starts much earlier. So it encompasses angina, it can escalate to unstable angina, and then, of course, to a heart attack. It is a condition produced when there is a mismatch between demand and supply. So heart being a muscle, it usually needs oxygen, it needs nutrition. That is carried to the heart through blood, but via arteries, we call them coronary arteries. When there is mismatch between the demand of the heart to consume more oxygen and the lack of supply, whether because of blood element or whether it is because of blood vessel or pipe element, unfortunately, that's what leads to ischemic heart disease.
So I think most of us know that the heart itself is responsible for pumping blood around the body to feed the rest of the body. I think what's less known is the heart needs that same oxygen, that same blood.
So ironically, heart being the pump that, as you mentioned, it pumps blood all over the body, it itself is a muscle, and being like any other muscle in the body, it needs oxygen, so it needs blood supply of its own, rightfully. And when the blood supply of its own is reduced or by any mechanism or another, patients usually end up having ischemic heart disease. If the blood supply is abruptly cut off completely, that's when you usually end up with a heart attack.
So with ischemic heart disease, how does the blood supply to the heart get cut off?
Yeah, so usually it is over time. The disease process, I know, starts as early as the second decades, and some later studies show that it starts as early as birth. So when you are born, the disease process actually starts. Over time, you start building cholesterol plaques inside the arteries of the heart, and to any other artery in the body, even to those of the brain, to the kidney, any other arteries. And the narrowing, or the more plaque you build, the more narrow the lumen of the artery becomes, to a point it becomes not sustaining the normal functions of the heart, and that's what we mean by ischemic heart disease. Now, heart attack, unfortunately, it is slightly a different mechanism, whereby you have the underlying cholesterol plaque, which is in the lumen of the blood vessel. When it ruptures or it exposes the blood element to the underlying cholesterol plaque, a clot forms, and it is really the clot that abruptly blocks the blood supply to the heart muscle. Usually the clot, after a day or two, it usually resolves, but unfortunately the damage to the heart muscle, we call it myocardium, has already happened.
So of course you mentioned before that before you have a heart attack, you may have years of this angina pain, and that angina pain is really related to that narrowing of your artery. Yeah?
Yep.
Yep.
So I think you might be lucky if you actually get symptoms, because if you have symptoms, you will probably attend to seek, or usually you should attend to seek medical attention. But unfortunately, ischemic heart disease can present as sudden death, and that is a bit unfortunate. So you have sometimes people who are completely fine and well without any symptoms. They probably sleep and they don't wake up. And that is in fact one known presentation of ischemic heart disease. But I have on the other spectrum, people who have angina, which is really just a fancy word for chest pain, or other symptoms or collective symptoms for pertaining to the heart, and they don't get it addressed. And unfortunately, most of the people who end up with heart attack, when we take a further detailed history in their past, they would actually admit that having chest pain, especially on exertion, probably feeling unusually tired, not as opposed to previous months. They might have shortness of breath, especially on exertion. Most of the ischemic heart disease, because it's demand and supply. So when you exert yourself, that is the time when you actually need more oxygen.
So when you're doing some kind of exercise where your heart rate goes up, that's when you start feeling that chest pain.
So so at rest, usually the demand is not that great. So the supply is probably matched, but it is really on exertion usually, or typically, where your demand increases and then the supply or lack of supply starts becoming more obvious. So I think if you do have chest pain especially, or shortness of breath, or you're feeling just unusually tired, and this is something chronic, it's not, you can feel unusually tired, you might feel chest pain from many other causes, but this is sort of something that is not attributed to, let's say, a flu, or attributed to feeling, just overworked, after a long day at work. But if you have ongoing symptoms, I think you definitely should see a doctor, probably your GP, who can do further investigations to delineate whether your symptoms are cardiac in origin. That means they could be attributed to ischemic heart disease, or due to other potential less harmful causes.
Could you describe this chest pain a bit more?
Yeah, so the classical angina that we talk about, it is a central chest pain, is usually described as heavy in nature. It not necessarily radiates, but it often does radiate to the neck. Usually people feel it like a throat block. It can also radiate to the back. Quite often it radiates to the shoulder and to the left upper arm. Is usually relieved by rest. So to differentiate angina, for example, from a heart attack pain. The heart attack, usually even if you're resting, you still get the pain, but angina is usually on exertion. As we mentioned, if you exert yourself, it happens, and if you rest, the pain usually goes away, and it is reproducible. So if you exert yourself to a certain level, as a patient, you would know that if I do that many flight of stairs or that many level of exertion, usually the same symptoms comes back again.
Okay, we need to go to a short break right now, but after we come back, we'll talk a little bit more about who gets ischemic heart disease. More after the break. Welcome back to Bula Wellness. We have Dr. Shaheen Nusser, who is a consultant cardiologist at CWM Hospital. Dr. Nusser, so before the break, we were talking about the symptoms of ischemic heart disease. Now I'd like to talk a little bit more about who gets ischemic heart disease and who gets heart attacks, who is most at risk.
So to be honest, there is nobody who is actually immune from developing ischemic heart disease. But definitely there are certain category or cohort of people that are more prone to develop ischemic heart disease than others. And it really has to do more with vascular risk factors. So for example, diabetes mellitus is a major contributing factor to coronary artery disease, the one we see. Smoking is another bad risk factor. High blood pressure, high cholesterol. These are all risk factors, and there are many more that can, if you do have them, then you are definitely at a much higher risk of developing coronary artery disease or ischemic heart disease. Now, there are certain risk factors that unfortunately you don't have much say in. For example, smoking, it is a modifiable risk factor, because if you know that you are a smoker, you can easily change and stop bad habit. If you know that, for example, your cholesterol is high, you can probably take medications, you can probably control with diet. But there are certain non-modifiable risk factors. For example, if you have a strong family history for ischemic heart disease, you have your parents, your dad had a heart attack at the age of 49 or below 50. That is unfortunately a risk factor that you slightly cannot really modify. So and the more risk factors you have, you are at a more higher risk of developing heart attack and of course ischemic heart disease. But as I mentioned, even people who are at low category, who are not smokers, they don't have cholesterol, they don't have diabetes, they don't have high blood pressure, they don't lead a sedentary lifestyle, they're quite active, still, unfortunately, can still develop a heart attack.
But the risk factors you can't really change, of course, are, like you said, the family history, age is another one. As well, as you get older, you're more likely to have a heart attack or have ischemic heart disease. What about ethnicity?
Ethnicity, it is well known that heart attack or ischemic heart diseases, there are certain ethnicities more prone to others. But ethnicity does not play a major role or factor. It is more of social, cultural habits rather than ethnicity. For example, we have seen people of certain ethnicity who migrate to a different country. The risk profile changes and it becomes adaptive to the country that they are in. I mean, for example, if you are Indian from India continent, you have a certain risk. But if you migrate to a different country, you'll still have the same ethnicity. Unfortunately, your risk profile will change, or it can change to the better, fortunately for you, but it can also change to the worse. So I have seen so many people of different ethnicities, and they all end up, I mean, when they come to us, they already have documented ischemic heart disease, but it is not a factor to say that, okay, if you are from certain ethnicity, you are protected. Or if you are from certain ethnicity, your risk is actually higher. And I mentioned about age. Definitely the disease process starts from childhood, probably from teens, I mean, later study from childhood. So of course, the more advanced age you are at a more high risk of having ischemic heart disease.
Okay. So what is the Ministry of Health doing? What services do we have for people who want to check if they have ischemic heart disease or already have it, or if I have a heart attack, for example?
I think we see two categories of patients. Some patients who have symptoms, and as we talked earlier in the first segment, the people who have chest pain or shortness of breath, they usually self-present to us. And I guess that is important. We do have certain tests that we can do. I mean, the simple one is just a simple resting ECG. We can stress them. We can do a stress ECG test.
This is when you run on the treadmill.
Oh, this is exactly when you run on a treadmill, and because we want to stimulate your heart, we want to stress it to see how it performs under stress. We can definitely also do an echocardiogram. And if you have positive stress tests, that means your stress test is not normal, or there are certain indications from an echocardiogram that your heart muscle is deprived of oxygen, then definitely we can do coronary angiography on you. It is a special test whereby we inject the arteries of your heart with a special medicine. We call it a dye, and we take a video X-ray clip of it. And that is probably the gold standard test to see if there are any narrowing or blockages in the arteries of the heart. And based on what we find, we usually plan the next step. We can probably put a stent. That means we literally blow up the blockage, or the neurolumen, just like a normal pipe. We blow it up and we leave a metal spring behind. And if the blockages are too much, then unfortunately you might end up even requiring open heart bypass surgery. Those are people who actually have chest pain or have symptoms. And we have other group of people who are out there who have risk factors, but they're really asymptomatic. I mean, I might be diabetic, I might be hypertensive, my cholesterol might be a bit on the higher side. I know I have family history, and I am a bit worried. And same, we also encourage those people to come to us, and we can do the screening tests initially. As you mentioned, stress test is a great test that I usually depend on in CWM. There are other modalities. One is a CT coronary angiogram. It is less invasive test than a coronary angiogram, but it gives us a great deal of information in a non-invasive manner about the anatomy of the coronary arteries.
Okay. So what happens, for example, if I suddenly have chest pain? What would you recommend me to do?
I think if you have chest pain and you think it might be heart in origin, I would suggest that you should go and see your doctor straight away. So you should present to the nearest health center. The doctors over there, the most important thing for us to be mindful that could it be a heart attack. If it turns out to be a heart attack, unfortunately for you, you will get transferred and probably admitted to our coronary care unit. There is certain medications that you will need to be on. And hopefully the most important medicine that we would like to administer, it is usually administered in a timely manner. So even if you get chest pain and you sleep on it, by the time you present to us, unfortunately we won't be able to administer the probably one of the most important drugs that would actually release the clot or lyse the clot, we call it a thrombolytic, and re-establish perfusion to your heart muscle. So if you have chest pain, please present to the nearest health center or medical facility as soon as possible. They will do the ECG. If it turns out to be the heart attack, you will come to CWM probably. You will get admitted to our coronary care unit. There will be an intense rehabilitation program. There will be medications that you will have to be adhered to. If you come with chest pain and they find that it is not a heart attack, but it is probably ischemic, that means it could be angina or unstable angina, they might not necessarily admit you, but then they will refer you to us for a stress test or for further investigations.
Okay. So I think that the key message there, of course, is if you get chest pain, please see your doctor. We would need to go to a quick break, and when we come back, more with Dr. Shaheen Nussair. Welcome back to Bula Wellness. We have Dr. Shaheen Nussair, consultant cardiologist at CWM Hospital. Dr. Nussair, before we went to the break, we talked a little bit about the services that are provided by the Ministry of Health for ischemic heart disease. Now I'd like to talk a little bit more about how do you prevent getting IHD in the first place?
I think that is probably one of the most cost-effective questions, because we don't want people to die, especially young people, or premature death we call them. And it literally, as we know, understanding the disease process starts from early childhood.
Yes.
So we definitely have to combat it. And there are well-documented risk factors. And we talked about the modifiable risk factors. So, for example, smoking. Definitely you have to avoid smoking. If you're a smoker and you want to live long, probably you should stop smoking. Not only from a ischemic heart disease point of view, but from other health benefits. If you do have diabetes, you will need your diabetes to be controlled. So you will definitely need to take pharmacological advice, take your medications. If you're on insulin, take your injections. If you do have high blood pressure, you definitely need your blood pressure to be controlled. Again, with cholesterol, you can control it with medications or diet. One bad enemy for ischemic heart disease is sedentary lifestyle. And I think there have been well-documented studies for every $1 you spend on a road pavement, you save $3 in health costs in the future. And it's just that, like we tell people to exercise, but we have to give them a good environment or atmosphere for them to exercise at. And I love to see, in Suva, we are quite fortunate to have a seawall, a park, it's good to see people actually using it and people training on the seawall. That is encouraging to see. Um, the diet, definitely we don't want fast food or unhealthy food, but unfortunately, well, then on the other aspect, we have to make healthy food accessible, or healthy food, at a reasonable cost for people to actually buy, because unhealthy food is usually cheaper and tastier, and unfortunately, we have to sell it to people, to live healthy. It comes with a cost, but it is if you want to live longer, not only live longer, but live healthy and happily longer. There are, of course, certain risk factors that unfortunately you cannot modify, but you can mitigate. The other thing is people who already have ischemic or documented ischemic heart disease. Unfortunately, those will have to be on medications. So to prevent a heart attack, apart from modifying risk factors, the ones that can be modified, we have certain medications that can reduce the chances of you from having a heart attack. We have certain medications that can remodel the function of your heart muscle should you have had a heart attack and survived the heart attack. And unfortunately, for people who already have ischemic heart disease or documented coronary artery disease or heart attack, they will need to be on medications to prevent heart failure and other dreadful complications that might happen from ischemic heart disease in the future.
So Dr. Shaheen, really, I think we've talked a lot about in previous episodes about diabetes and lifestyle diseases. So there's a common theme here that diet and exercise to prevent getting the diseases in the first place. And it's common across diabetes, kidney disease, ischemic heart disease. And then you're saying, of course, if you do have diabetes, for example, you need to be extra vigilant for ischemic heart disease because the risk is much more. And then, of course, if you have ischemic heart disease, basically having a very good relationship with your doctor, having regular checkups, making sure that you're on your medications. And so it's very similar to those other diseases as well.
Yeah, I think we are living in the same human body. As I mentioned, the same arteries that supply the heart are literally the same arteries that supply the brain. And in fact, the same arteries that supply the kidney. So why you should have cholesterol plaque building in the arteries of the heart and getting ischemic heart disease, but not, for example, the arteries of your brain and ending up with a stroke as opposed to a heart attack. They all go hand in hand. It is the same vascular-tree. And as you mentioned rightfully, you control your risk factors. Now, if you have multiple vascular risk factors, even if you are asymptomatic, you should come for screening. So if you are diabetic, of course, you will definitely need to control the diabetes. You will definitely need to indulge more into physical activities and, healthy habits of not smoking and avoiding alcohol and so forth. But in addition to all that, you'll also need to come for stress test, for example, or, you'll need to definitely see your doctor from an ischemic heart point of view. Probably you talked about diabetic foot sepsis,
yes,
but also you need to talk, as a GP, you'll also have to address with the patient about the risk of ischemic heart disease at least.
Yes, exactly. Diabetes, of course, is type 2 diabetes is a lifelong chronic disease, and there are a number of different checks you need to have along the way. We've talked about kidney checks, foot checks, and of course now is ischemic heart disease, as you mentioned. So it's really people taking ownership of their own health. Is there any message you would like to give to the public before we end this episode regarding IHD?
Yeah, I think if a message at all, I just need to tell the public that we have the means to treat your ischemic heart disease. It is a disease process that is happening with or without your consent, in a way that, if you live up to, if I take a cohort of 100-year-old people and I study the coronary arteries, probably none of them will have normal arteries. They will have coronary artery disease. But we have means of addressing you if you have ischemic heart disease. We don't want you to reach a stage where you actually require a cardiologist input towards your heart. We want you to start from the beginning. Healthy living. There is no substitute for a good exercise, a healthy meal, controlling or avoiding bad habits like smoking, alcohol. And I think if you achieve that, probably you will get much more mileage from your body that, God gifted to you in the future. As opposed if to abuse yourself at a young age, probably you will not cross 50 years, 60 years. Even if you cross, your life will be miserable. You will be in probably heart failure. You will not have the quality of life that you deserve.
So, of course, it's a combination of quality of life and longevity, or the length of your life, that we're trying to extend. Thank you very much, Dr. Nusser, for coming in today.
Thank you, Dr. Sahukhan.
Unfortunately, we've run out of time again, but I hope you've learned a lot from this episode of Bula Wellness. If you have queries about the show or the topic today, like or contact us on Facebook, Bula Wellness FBC TV, or write to us at bulawellness@fbc.com.fj. Make sure to join us again at the same time next week. Until then, good night.